In this new video, we will study the various structures of the lateral side of the knee, which I suggest studying from front to back for practical reasons. Let's jump right into the anatomy. Here is a diagram of the anatomy of the lateral aspect of the knee. The most anterior structure of the lateral compartment is the iliotibial band. This large fibrous band inserts proximally on the iliac crest, where two muscles exert tension on it, the tensor fasciae lata in front and the gluteus maximus in back. It takes a vertical trajectory along the lateral side of the thigh, where it reinforces the deep crural fascia, to end on a bony landmark at the proximal end of the tibia, called Gerdy's tubercle. At its distal end, it passes close to the lateral femoral epicondyle, which is a potential impingement site in the context of iliotibial band syndrome. In the back is the anterolateral ligament, a thin structure reinforcing the joint capsule that inserts on the lateral femoral epicondyle to terminate on the lateral side of the tibial epiphysis. This structure is often injured during anterior cruciate ligament tears in the form of an avulsion fracture of its distal insertion, which is called a second fracture. The popliteal muscle, which is located on the posterior side of the knee, inserts laterally through a short tendon which starts in a small bone fossa on the lateral side of the distal femur. More posteriorly, you will find the lateral collateral ligament, which provides the knee with varus stability. This ligament starts on the lateral femoral epicondyle, then follows a posterior and oblique path until it inserts distally on the head of the fibula. At this level, it passes between the two fibular arms of the biceps femoris tendon, which is the most posterior tendinous structure in the lateral compartment. This muscle is one of the hamstring muscles. It is the most lateral structure, with a distal tendon made up of two fibular arms, superficial and deep, and one tibial arm, which inserts on the posterolateral side of the tibia. The lateral femoral tibial joint line and the lateral meniscus are deep to all of these structures. Only their superficial parts can be seen on ultrasound. Lastly, the proximal tibiofibular joint is the most posterior structure in the lateral compartment, joining the proximal parts of the tibia and fibula. As a joint, it's not very mobile. It is closely linked biomechanically with the distal tibiofibular joint at the ankle and is most often damaged when the latter is injured. Again, the exam will be done with the knee slightly flexed, about 15 to 20 degrees, to unlock the knee and make it easier to analyze the various tendon and ligament structures. The iliotibial band will be explored on a coronal view, parallel to its long axis, by focusing mainly on where it contacts the lateral femoral epicondyle, where impingement can happen between the two structures. By sliding the probe down, we can also analyze its distal insertion on Gerdy's tubercle, which can be the site of enteropathy. The anterolateral ligament is a very thin structure that is often difficult to see on imaging, making the use of a high-frequency probe particularly worthwhile. It is on a coronal view, parallel to its long axis, that this ligament is easiest to analyze, where it spans from the lateral femoral epicondyle to the proximal portion of the tibial epiphysis. We need to focus specifically on the distal end of the ligament to look for an avulsion fracture, or second fracture, which is a sentinel sign of an anterior cruciate ligament tear. The lateral tibiofemoral joint and the lateral meniscus are located deep to the various tendon and ligament structures on the lateral side of the knee. We can clearly see the bony cortex of the femoral and tibial epiphysis, which appear as hyperechoic lines. One of the main findings at this level would be signs of osteoarthritis that present as joint narrowing and osteophytes. Between these two bones, you will find the lateral meniscus. Only its periphery can be seen with ultrasound. A normal meniscus has an homogeneous hyperechoic signal. The first step is to evaluate its position by looking for a greater than 3 mm extrusion relative to the bony landmarks of the joint. We can also look for potential tears in the form of line or streaks. The tendon of the popliteus muscle will be analyzed on a coronal view at the level of the lateral femoral epicondyle, where it originates in a small bony fossa, which is easy to locate. The main pathological finding here would be the presence of tendinopathy or enthesopathy. Next, we will analyze the lateral collateral ligament using a coronal view parallel to its long axis by directing the probe downward and backward towards the fibular head. This ligament is always taught in the examination position. The main finding would be signs of a sprain, which is typically graded in 3 stages. A simple strain presents as an hypoechoic thickening, stage 2 is a partial tear, or even stage 3 is a complete tear. To differentiate between the latter two, we can use a varus stress test. To do this, we ask our subject to bring their feet together. Then we place the probe on the lateral side to watch the ligament while pressing on the medial side of the knee to check whether or not the tension on the ligament remains. The distal tendon of the biceps femoris muscle inserts jointly with the lateral collateral ligament at the head of the fibula. To differentiate between these two structures on an axial view, we can use anisotropy. In fact, by slightly tilting the probe, we can see that the echogenicity of these two anatomical structures is slightly different since their fibers are oriented differently. We can generate a fairly characteristic image that is sometimes called Pac-Man. The two fibular arms of the biceps femoris tendon make up the pudgy face of this renowned character, while the little dot in the middle, which is more hypoechoic, corresponds to the lateral collateral ligament. The proximal tibiofibular joint will be the last structure to analyze. We can examine it using either the anterior or posterior approach. We are looking mainly for signs of arthropathy or even effusion that can sometimes fuel synovial cysts, which can compress the neighboring structures. Here is a typical example of impingement on the lateral side of the knee. In this case, we can see hypoechoic thickening of the iliotibial band where it contacts the lateral femoral epicondyle. There is considerable fluid collection on its deep surface, corresponding to early bursitis in the context of this iliotibial band syndrome, shown on an axial, then coronal view. In Doppler mode, there was increased blood flow at the site of this bursitis. In these patients, it may be useful to increase the sensitivity of the exam by asking them to do an activity that triggers symptoms before coming for the ultrasound exam. This sometimes makes it possible to uncover early, subtle conditions. Ultrasound can also be used to guide a local corticosteroid injection by precisely targeting the pathological area. This ends our survey of the lateral aspect of the knee, which, as you have seen, has many structures to analyze. Thanks a lot for listening.